Good morning and welcome. Thank you for joining me this morning. I want to point out that I guess my slides were a little bit too large to be loaded into the BrainShark system this morning, so I am sharing my desktop, and that means that I can't see the chat box. So my request will be, because I don't have anybody manning the chat box for me today either, Sherry can answer technical questions about the webinar process itself, but content questions about the webinar, if you will email me those, if I don't answer them during the webinar, I would appreciate it, and I'll be able to get back to you after the webinar. So my email address is on the very last slide of the handout, and of course will also be on the last slide that you'll see today. So I want to get started and just tell you briefly, we're going to go over cognition and deficits, a brief cognitive rehab overview, and then I'm going to talk some about cognitive rehab with older adults and cognitive deficits and how they affect functional abilities. So just to get started, I need to talk first a little bit about cognition. It's defined as the mental action or process of acquiring knowledge and understanding through thought, experience, and the senses. That is a Wikipedia definition, but it's an easy to understand definition. So cognition encompasses those processes of knowing, including attending, remembering, and reasoning, also the content of the processes, such as the concepts and the memories. And that's from APA, from the American Psychological Association. So cognition encompasses knowledge, attention, memory, judgment, reasoning, comprehension, and language. And without cognition, we can't use our existing knowledge or generate new knowledge. These are internal mental processes that may be tested with behavioral methods, but they're not directly observable if you think about them. So just briefly, some of the functional areas of the brain. This is, of course, an extremely simplified model here, but again, it's also an easy to understand model just to talk about or to demonstrate that each of the cognitive functions is associated with a particular area of the brain, and I should say not each, but most. So starting on the upper left in the frontal lobe, you have thinking and planning and problem solving and decision making. We refer to most of those as executive functions. This area is also responsible for impulse control or response inhibition. Below that you see the temporal lobe, which controls memory and speech and hearing and facial recognition. At the rear of the brain is the occipital lobe, where vision and the processing of visual information is located. The parietal lobe controls perception, classification of objects, spelling, number recognition, and VisuoSpatial Processing. If you were to try to mark the attention areas of the brain, they would pretty much be all over. There are attention areas in virtually every area of the brain, in the frontal lobe, the temporal lobe, the parietal lobe, the cerebellum, and the brainstem. And you see here, you're looking at the left side of the brain, and the functional areas are not limited to just the left side of the brain. The same functional areas are found in the right hemisphere. Generally speaking, both hemispheres perform the same or can perform the same cognitive functions, and they usually share the workload. But there is some specialization on particular tasks. And again, there are a lot of diagrams available that show the functional areas of the brain. This is just an easy to understand one, and so I like to use it when talking about functional areas of the brain. If you really wanted a more realistic diagram, it would kind of look like this, with each area of the brain talking back and forth with multiple other areas just to perform a single function. You can imagine a complex function. But this is also a kind of an overly complex way of looking at it. Not that it's not indicative of the complexity, but it becomes difficult to discuss it. So the simplified model is one that is used often just in terms of discussion. I want to show you this brief video about what the brain's wiring looks like. There is no sound here, but there's some words on the screen that will tell you what you're looking at, and I will also give you a little bit of information. This is a really detailed scan of what the wiring of the human brain looks like. I got this from the BBC website recently. Saw this video and just kind of thought it was perfect to show the complexity. This was produced at Cardiff University by an MRI machine. And then you can see there the process by which they color-coded and show this. I just thought this was a really nice way of showing, again, that complexity of communication. This is a 7 Tesla scanner, and this scanner is being used for research into many neurological conditions, including multiple sclerosis and schizophrenia and dementia and epilepsy. As you see there. Okay. That's the end of that. I just wanted to show you that because, again, it just kind of fascinated me when I saw it. It just really details the complexity of the communication process throughout the brain. The physical mechanism of cognition involves a couple of steps. First, the formation of connections between the neurons in the brain, and then the sending and receiving of signals between those connected neurons. And any factor that interferes with those processes creates a barrier to cognition, what we call a cognitive deficit. So cognitive skills can be lost or altered due to any of those barriers or any damage that is resulting from disease or injury. And cognitive functioning difficulties then often affect behavior and the ability to complete tasks. Other areas of health focus on prevention and treatment of disease, but broadly, rehabilitation mainly focuses on the enhancement of human functioning and quality of life. So there's a connection between disease or injury and the ability to function. And a disease may be cured, but the disability may remain, or a disability may be reduced even with the presence of disease or permanent injury. So many people think of rehab as just improving physical disability, but rehab, of course, is not limited to this. Cognitive rehab attempts to enhance functioning and independence in adults with cognitive deficits or impairments, many of which are the result of brain damage or disease, most commonly following TBI or stroke, and we'll talk some more about that in a minute. Actually, starting now, cognitive deficits can be either durable or temporary, and we're kind of going to focus on some of the durable causes, which include brain injury, such as stroke or traumatic brain injury or brain tumors, neurological disorders, such as multiple sclerosis or epilepsy, congenital defects, such as Down syndrome or autism, and psychiatric disorders, such as depression or schizophrenia, and then you can see some of the temporary causes there as well. I'm going to talk briefly about a few of those durable causes. So beginning with stroke. A stroke is defined as the sudden damage or death of brain cells due to lack of oxygen, and that can be caused either by blockage of blood flow or rupture of an artery to the brain. Stroke is the leading cause of disability in the United States, and it's the 4th leading cause of death. That disrupted circulation that kills brain tissue can just devastate the brain. It can leave neurological impairments that include paralysis, partial or total loss of language, and some severe cognitive deficits. In the United States, it's the 4th leading cause of death. Some strokes are relatively minor, causing little, if any, lasting damage. And then, although they are sudden, a brain injury stroke often will inflict damage over the course of hours or even days, or it can be apparent very suddenly, or it can be slow to be observable. So prompt, effective treatment really does mean the difference between a good recovery and permanent disability or death. So there's 2 types of strokes, the blockage of blood flow, which we call an ischemic stroke, and depending on the exact location of the blockage, an ischemic stroke can affect a very localized area or a very broad area. If the blockage is in a smaller artery out toward the end of a network, it may affect a very small localized area and perhaps only one specific cognitive function. The other 12%, about 88% of all strokes are ischemic. That's what I was looking for. And the other 12% are hemorrhagic, which is a rupture of an artery in the brain. Hemorrhagic strokes tend to affect a broader area And again, of course, that can impact multiple lobes and therefore multiple cognitive functions. So again, basically only an ischemic stroke in a small artery may have a localized effect, but all other strokes are more global and may affect multiple cognitive functions. So the duration of the blood flow interruption determines how severe the cell damage is. In general, an interruption of more than about 2 minutes is going to cause cell death, which is irreversible. A shorter interruption may cause cell damage, which might be reversible. Pressure from a hemorrhagic stroke on neighboring areas of the brain, though, can also cause cell damage. Again, that might be reversible. So damage can be, in many instances, reversible. Death, of course, is not. Prognosis at about 90 days, about 60% still have a mild impairment, while almost 20% will still have a severe impairment. And the mortality rate at 3 months is about 15%, but if you go out about 2.5 years, the mortality rate jumps to 54%. Of course, other conditions and other factors play a role in that as well. So no matter where you live in the world, though, the major risk factor for stroke is age. And with the aging boomer generation, we really can expect a significant increase in numbers of people affected by stroke. The things that predict functional outcome in stroke are age, functional status, and disease duration on admission to the hospital, comorbidities, and cognitive functions at the time of the stroke or injury will all affect outcome. So now looking at traumatic brain injuries, or TBI, they're defined as the sudden damage or death of brain cells due to a violent blow or jolt to the head or by an object penetrating the skull. TBI is the leading cause of death for anyone under the age of 45. The damage here is caused by bruising, by hemorrhaging, or stretching of the brain tissue. And because of the cause, or the various causes of TBI, they tend to be global, affecting multiple areas of the brain and multiple cognitive functions. And then there can be injury to opposite areas from the area of impact, as you can see here on this picture. Those are called contre-coup injuries. In the United States, the motor vehicle and pedestrian accidents are by far the leading cause of all the TBIs, and they account for about 50% of such injuries. Falls are the second leading cause, and they account for more than 20% of all TBIs. Gunshots and assaults and sports or recreational accidents are the next most prevalent causes of TBI. Overall, about 1 million TBI injuries are estimated to occur in the United States every year. About every 15 seconds, someone in the United States sustains a TBI. Of those, about 375,000 are hospitalized, 50,000 result in death, and 100,000 individuals sustain moderate to severe brain injuries that result in lifelong disabling conditions. And that's just the number that's reported through emergency room visits. A lot more do go unreported or receive no medical care. About 52,000 people die from TBI. And then a significant percentage of those survivors are going to have moderate to severe disabilities that last, for a varying length of time. Okay, I showed you this one, or told you this anyway. All right, so I'm not going to focus on these very much, but just, these are things that are familiar to you, most likely, characteristics of a brain injury. There are physical characteristics that we are probably most familiar with, really, and thinking about what TBIs and strokes, the results of those. These are the kind of more observable effects that we think of. And then the cognitive characteristics, and those, of course, include things that we're kind of talking about today: impaired attention and concentration, memory impairment for learning and recall, impaired problem-solving and decision-making, slowed information processing, impulsive thinking, poor organization, planning, and sequencing, impaired concept formation and abstract thinking, inflexible thinking and mental rigidity, and poor judgment, especially in social situations. So you can see that you can imagine that there are some pretty impactful consequences from the types of cognitive characteristics that you see after a brain injury. And then behavioral as well. Again, I'm not going to go through these, but of course these also have sometimes long-lasting effects on the person's life. Neurodegenerative causes of cognitive deficits include things like multiple sclerosis and dementia. Both of these result in a slow decline in cognitive function. There's about 400,000 MS patients in the U.S., which is a lot, but of course the real gorilla is dementia. There's currently more than 5 million cases in the U.S., and that, of course, is also rising as the number of older adults rises. The number one cause of dementia is Alzheimer's disease, and the predominant risk factor for Alzheimer's is, again, age. So, of course, the number of patients with dementia is expected to continue to increase. Cognitive deficits have a really significant negative impact on activities of daily living and on quality of life, as you can imagine, including in cases with dementia. Again, where the decline is typically more slow. Memory and planning problems affect things like dressing and grooming and cooking. Attention issues and visual processing deficits increase the risk of collisions and trips and falls. Cognitive deficits can cause mood issues and motivation problems, which can affect all activities of daily living, and physical or occupational therapy after rehab, of course. Cognitive deficits can have a significant impact on the outcome or on just the process of therapy. So any cognitive deficit that can, of course, affect patients' ability to drive or return to work for a younger adult, but also can be one of the things that drives the decision about independent living, as we're going to get to in just a little bit. So talking about cognitive rehab, we understand some about cognitive deficits, but what we can do about most of them, or many of them, is to work with a cognitive rehab program. During most of the 20th century, we thought that brain structure was pretty fixed, pretty solidified after a critical period in early childhood. And then after that early period, if you experienced a brain trauma, we just kind of assumed that you would have to live with the resulting cognitive deficits. But in the last several decades, researchers have shown that the brain's physical structure and functional organization can and does change in adults. This concept is called neuroplasticity. It's the brain's ability to remold and rewire itself. Neuroplasticity is a response to changes in behavior and environment, thinking, or emotions. And the key to this, in many instances, is repetition. The science of how the brain changes its structure and function in response to input is another way of thinking about neuroplasticity, how the brain changes its structure and function in response to input. The brain's designed to grow new structures and to create new pathways in the presence of damage or an environmental challenge. And again, that's something that we didn't fully understand, didn't understand at all in the past. So rehab, then, is a helpful process to change the brain and to increase a person's function and skills. Other terms that are used to refer to neuroplasticity are the brain plasticity or cortical plasticity or cortical remapping. This is, again, it's the changing of neurons, the organization or reorganization of their networks and their function via new experiences. This was an idea that was really first proposed in 1890 by William James in the Principles of Psychology, but it was an idea that was largely neglected for the next 50 years. And then again, during the latter part of the 20th century, we began to conduct rehab exercises after World War II with brain-injured soldiers. We began to study brain injuries and rehab, and so we've seen a tremendous increase in both research and in processes of cognitive rehab. Neuroplasticity really is a fundamental issue that supports that scientific basis for treatment of acquired brain injury with goal-directed experiential therapeutic programs in that context of rehab. Functional rehab programs support neuroplasticity with goal-directed programs in their rehab. So let's talk about ways that cognitive functions are restored. One way is restitution, that is the reestablishing and strengthening of damaged neural pathways. This is a healing process, and it applies in situations where neurons have been damaged but are not dead. And so this can be from that short-term ischemia, or maybe pressure damage from a hemorrhagic stroke, or from stretching caused by a TBI. So again, these are neural pathways that are damaged but not dead, and they can be, in many instances, reestablished and strengthened. So this process aims at reinforcing or strengthening or restoring those impaired skills. It includes the repeated exercise of things like standardized cognitive tests of increasing difficulty, things that target specific cognitive domains like selective attention or memory for new information. The purpose of this kind of training is to stimulate poorly functioning neurological pathways in the brain in order to maximize their efficiency and their effectiveness. It really aims to overcome that damage. Now, these improvements, these functional improvements, are then made over many months or even years. So another way that cognitive functions are restored is reorganization, and that is developing and strengthening new neural pathways. So this is a neuroplastic process which may involve a slight detour to go around a damaged area or a total reassignment of a cognitive function to a completely different area of the brain. In reassignment, a function is often reassigned to the contralateral side of the brain, the opposite area, the same area on the opposite side from the damaged area. Another way of recovering cognitive function, then, is compensation, and that is the use of new strategies or external aids. So the most common of these are some you're familiar with, I'm sure, memory strategies or external memory aids like notes or day planners. Compensatory approaches teach ways of bypassing or compensating for the impaired function. So they're the development of new compensatory skills to enhance daily performance. Both retained skills and functional reorganization are used to learn new strategies. This is also called strategy training sometimes, and it often involves the use, again, of external tools like diaries and electronics and adaptive equipment and yellow stickies like you see here. The use of assistive technologies such as calendars, alarms, electronic memory devices, and those things are increasing rapidly too as technology progresses. In terms of practical therapy, there's not any real difference between restitution and reorganization. Whether the old neural pathways are being repaired or new ones are being built, the results are the same. The neural pathway and the cognitive function appear to be restored. Compensation, on the other hand, is used to deal with existing cognitive deficits without restoring neural function. So there's that difference. But they're not mutually exclusive. They really should be undertaken at the same time. Treatments that attempt to restore lost functions need to be undertaken at the same time as teaching compensatory strategies to minimize those cognitive impairments. So cognitive rehab can promote and accelerate restitution, it can promote and accelerate reorganization, and it can be used to teach and practice internal compensation strategies and the use of external aids. And then, of course, in addition to these, we use things like education and functional application. Those are really important in the cognitive rehab approach. In the majority of domains, research will indicate that some form of strategy or compensation-based intervention that is set in the context or clearly transferable to functional settings is going to be the most effective approach. Okay, so let's move to thinking about recovery of cognitive functions with different types of therapy programs. So cognitive rehab therapy is defined as or can be defined. One definition is a therapy program to help cognitively impaired individuals restore normal functioning or to compensate for cognitive deficits. So whatever the mix of restoration or reorganization or compensation approaches, the therapy, though, needs to be systematic and structured and repetitive according to the needs of each particular patient. It should be progressive. It should adapt to each training subject with a repetition and a fairly intense training schedule, of course, depending on the needs of the particular patient. There are specific therapies designed for each of the cognitive functions. We're not going to go through the specific therapies today themselves. They are widely established in the literature. But cognitive skills themselves should be seen as a hierarchy, with attention skills seen as the underlying foundation for all other cognitive skills. Assessment and treatment should really always begin at this level if problems are evident. Assessment and screening there certainly should be done at the outset. And if there is no impairment in attention, then it's not necessary to begin there. But the screening at the outset is necessary. Executive function and awareness should be worked on pretty much at all stages. And it's also important to determine whether any often reported memory difficulties are dependent on attention or information processing failures, or if they are manifestations of impulsivity attention deficits or information processing failures, or if they're the result of interactions among those, because that also will help prioritize training. So thorough assessment is really important at the outset in thinking about what the plan is going to be for a particular patient. Interventions are the most successful as a whole when they're structured, they're systematic, they're goal-directed, they're individualized, they involve learning and practice and social contact and a relevant context for the particular patient. Luria theorized that recovery of function occurs through new learned connections established through cognitive exercises specifically targeted at the source of problems for the basic processes that have been disrupted. So in the process-specific approach to cognitive rehab, the drills or practices are a means of attacking the deficient cognitive capacity, but the exercises themselves don't have any inherent value. There is a consensus paper, Cicerone et al. From 2005, that notes the evidence of cognitive rehab, and I'll refer to it a couple times today, but it's an important one to look at if you are interested. It is a meta-analysis, so you can certainly get a lot of other information from those references as well. But one of the things that it notes is that holistic approaches that integrate both emotional adjustment and cognitive strategies and skills have more positive effects on outcome. So I mentioned targeted. We all understand the difference between just activity and rehabilitation therapy. Activity is really great, but it's random. It doesn't address a specific deficit or need. And so to get maximum therapeutic effect, a task that's going to be part of a rehab program needs to be targeted and repetitive and supported. And when it is targeted and repetitive and supported, then we call it rehab therapy. And remember, repetition is one of those keys to neuroplasticity, and neuroplasticity is one of the foundations of cognitive rehab. So looking at cognitive rehab with older adults, how is it different than with younger adults? It's different in these ways. The epidemiology, the mechanism of injury, morbidity and mortality, functional outcomes, some age-related brain changes, and age-related cognitive outcomes. Older adults admitted to acute care with severe brain injury do typically have a poorer prognosis, with few being discharged with good functional outcome. But of course, age and, if relevant, Glasgow Coma Scale scores are independent predictors of the poor functional outcome. Severity of injury, time since injury, age, comorbidities. Okay, well, we'll talk about those as we go through these slides. But those are all really important factors as well. So looking at the epidemiology, just the difference between female and male injury rates, although TBI is really common or most common among young adult males, older adults are also a very high-risk group but falls rather than motor vehicle accidents are the major cause of injury. Adults over 65 have the highest rates of TBI-related hospitalization. The annual hospital charges for treating TBI patients 65 or over in 2010 was over $2 billion. Older adults are hospitalized more often for TBIs. They have 2 times the mortality from TBI. And then, of course, again, the number of adults is on the rise. The mechanism of injury is different. Injuries in older adults just in general are different from younger adults. Subdural hematomas and diffuse axonal injury and focal contusions are more common in older adults. An estimated 85% of older adults who have TBIs they're mild to moderate in severity, possibly because motor vehicle accidents involving older adults tend to be at lower speed. Crashes between vehicles and pedestrians involving older adults tend to occur at crosswalks and parking lots, and so those can be lower velocity than car-to-car crashes. Of course, assaults can occur. And just the mechanism of injury is just different. In younger adults, motor vehicle crashes are the most common cause. In older adults, it's falls. And falls predict functional decline. You can see that falls are the fifth leading cause of death in people 65 or over. About half of nursing home residents fall every year. Patients with dementia, 60% of patients with dementia fall every year. The death rate attributable to falls increases with age, and of course much of that is due to head injury from the fall. So increases in mortality and morbidity after brain injury in older adults compared to younger people. Older adults with TBI have higher mortality, both acute and long-term. They more likely have other health problems that affect the recovery, such as cardiac problems, pulmonary problems, and multi-system organ failure. The older adult brain has a decreased ability to repair itself. They're more susceptible to medical complications. You can see cerebral vascular events and setting of trauma-related hypotension, adverse effects of anemia due to blood loss and trauma. They're more likely, again, to have pulmonary and cardiac complications. This increased mortality is associated with things like abnormal gait, prescriptions for respiratory medications, diabetes, additional medications, things like that in some studies. Compared to younger adults with brain injury, older adults undergo more in-hospital procedures, including imaging and neurosurgery. They have longer acute care hospital stays. They're more likely to require continued medical care. In one study of patients, older patients were found to have less severe injuries on the Glasgow Coma scale, but they were slightly more disabled at discharge. And age had a significant negative influence on those disability scores, both at discharge and 5 years after the TBI. Older adults show a greater decline over the first 5 years after TBI than younger patients. Functional outcomes, there was a study that showed that compared to younger people, older adults with TBI have poorer short-term functional outcomes, overall worse functional outcome, and greater levels of disability. Another study of people over 55 versus younger than 55 who were matched for injury severity and gender in the older group had significantly longer mean length of rehab stay, higher total rehab charges, slower rate of improvement on functional measures, and a higher rate of discharge to nursing home. The injury severity is important, as I mentioned earlier. In cases of TBI that are uncomplicated by multiple trauma, older adults do have the potential to achieve functional outcomes that are comparable to younger patients, but the recovery and rehab may take longer and at a greater expense. But it is less likely that older adults will have other complicating conditions than in younger. And again, as I mentioned a minute ago, aging in the brain, there's a difference, in the age of the brain and how that affects recovery. So there may be a decrease in synthesis of nerve growth factor, making neuronal repair more difficult. Age-related cerebral vascular changes, which are much more common in older adults, obviously, can lead to reduction in cerebral perfusion and reduced regional cerebral metabolism. Overall brain shrinkage due to atrophy is more common. There's some chemical changes that are more likely to take place with age, as you can see. And those all have a significant effect on the process of and the outcomes of rehab. So the aging brain is just really more vulnerable to damage as a whole. Obviously, I sound like I'm being stereotypical, and that's because those numbers exist for a reason. But I don't mean to overlook the outliers. just a more significant injury can result from a mild blow, for a number of reasons. There's less reserve, there may be those pre-existing medical conditions, there's polypharmacy issues, the deficits are more pronounced, there's poorer functional outcomes, and then, of course, cognitive decline. So this is just a comparison. If you look at some of the age-related factors in a given older adult and TBI-related factors, you can see they're pretty comparable. And then cognitive outcome. Again, older adults are at risk for poorer cognitive outcome following brain injury. Possibly it's possible that cognitive impairment predisposed the injury or that there's some decreased cognitive reserve present, as I mentioned, and then the effects of medications are always important. So again, the data really suggests that older individuals are more vulnerable to the effects of brain injury. On the other hand, from a rehab perspective, older adults have a more stable lifestyle, they have better coping skills, they often have more support, not always. They have fewer life demands than younger individuals, and all of those factors can have a positive impact on rehab outcomes. And while there's evidence of better recovery of some basic functions in younger versus older adults, there is no reason to believe that older individuals are not able to learn to compensate for residual deficits just as well as younger individuals. And there's really been a considerable interest in how individuals learn to compensate for the cognitive deficits just associated with normal aging, or the cognitive declines, I should say. So research is really looking, a lot at compensatory, both physical and behavioral compensatory strategies or compensatory patterns that are associated with normal aging. Although we expect the recovery of underlying processes to be more limited with an older patient, many older individuals have been shown to develop pretty effective compensatory skills and are often better able to adapt some of the changes associated with neurological injury or disease than younger individuals. So rehab evaluation really starts in ICU to determine acute needs and start long-term planning with an older adult, with anyone, but focus on older adults here. So it will continue throughout the course in other settings, including pre-injury activity level information, evaluation and consideration of potential pre-existing cognitive issues, certainly pre-existing medical issues, new cognitive status, premorbid and new behavioral issues. All of those are really important in planning the intensity of therapies and in setting goals. So it's important to determine the cognitive and the behavioral status as they pertain to the ability to tolerate physical and cognitive activities in rehab. And then, of course, the planning needs to incorporate information about physical impairments as well as cognitive impairments, so hemiparesis or dysphagia or incontinence or impaired cognition. And then the functional level of the person, premorbid and post whatever the injury was or is, looking at mobility status and activities of daily living abilities. And if the reason for rehab is stroke, then of course, they have to also consider risk factors for further CVA. That's an ongoing part of even the cognitive rehab. So following a head injury, it's really typical that an individual remains in acute care long enough to monitor and manage those basic systems. And then following acute care, individuals may complete further rehab in either a hospital-based or a community setting, sometimes also discharged to home or long-term care facility. Not sometimes, but, the timing of that is individual. And then acute care, older patients really have to be aggressively triaged and monitored closely and should be referred to geriatric medical staff for longer-term assistance as well. Those transitions, especially utilizing people who are familiar with working with older adults, are really beneficial to optimizing good outcome. So cognitive deficits usually affect a specific cognitive function or more than one specific cognitive functions. About 80% of stroke and TBI will have an attention deficit. 65% will have memory deficits. About 75% will have executive function deficits. But attention, memory, and executive function are the most common cognitive deficits, no matter the cause. And cognitive rehab addresses most of the cognitive deficits that we see with stroke or TBI or dementia or MS. The goals of cognitive rehab are to enhance the person's capacity to process and interpret information and to improve the person's ability to function in all aspects of family and community life. And so restorative training focuses on improving a specific cognitive function, whereas the compensatory training focuses on adapting to the presence of a cognitive deficit. Those compensatory approaches certainly may have some restorative effects at sometimes. Some cognitive rehab programs rely on a single strategy, and others will use an integrated or interdisciplinary approach. The multidisciplinary approach in any cognitive rehab program is also really important. But a single strategy program will often target either an isolated cognitive function or multiple functions concurrently. Overall, the aim of the cognitive rehab is again, to reduce the impairment caused by damage to the brain. So the aim is for the patient to achieve as much independence as possible through as much of his or her own means as possible. And then, the main criteria for measuring success often depends or always depends on the specific goals of the client, the client's or the patient's subjective opinion about the change of his or her quality of life. The specific goals, need to be tailored to enhance the individual's ability to function as independently as possible in the least restrictive setting, the end result being to improve quality of life and real-life skills. Goal-oriented cognitive rehab interventions really aim to draw on the retained strengths to support adaptive behavior and to achieve optimum levels of well-being by targeting performance on personally relevant goals. So that evaluation of the person's cognitive status at the outset needs to be comprehensive and address, again, the things we talked about earlier: arousal, alertness, attention, orientation, memory, language, agnosia, visuospatial perceptual function, praxis, and executive functions such as insight and judgment and social cognition and problem solving and abstract reasoning and initiation and planning and organization. The cognitive rehab with an older adult needs to be undertaken in that context of a thorough understanding of any other chronic disease that they may have, that with any premorbid limitations that they may have. The causes of disability in older adults are likely to be related to chronic disease, either as an acute disabling event due to the chronic disease, like a stroke due to CVA, or a fall due to osteoporosis, or a progressively disabling chronic disease. It's very important to understand, though, that cognitive rehab is not effective at reversing dementia or the cognitive effects of other neurodegenerative diseases, but is instead the program to restore or improve functioning due to, brain injury due to stroke or other impairment, other injury. Here is a picture of that meta-analysis that I mentioned earlier. Again, it's a really good piece of literature or meta-analysis that will give you a lot of information about the evidence we have for cognitive rehab, both in younger and older adults. A large body of evidence has really emerged supporting the use of cognitive rehab after stroke or TBI, for MS and for dementia. And their conclusions are, that there is substantial evidence to support interventions for attention and memory and social communication skills and executive function and visual spatial rehab and so forth. And, without going into the details of these meta-analyses, I wanted you to see that there is evidence and know where to find it. Also, that there is evidence for computer-assisted cognitive rehab, which is, of course, a rapidly growing area. And you should pay close attention to the differences between cognitive rehab, computer training used in, or computer-assisted cognitive rehab, and the types of just cognitive games that are out there. So that's a whole other topic, and it's an important one to pay attention to. Looking quickly at cognitive deficits and functional ability, cognitive impairment and injury often lead to a decrease in functional capacity, so as I mentioned earlier, so it often affects rehab outcome in stroke. It often has a negative effect on functional outcome and activities of daily living. So functional status is the ability to function in the arena of everyday living, and activities of daily living are those that patients should be able to do in order to live alone safely. ADLs being the ability to perform basic self-care tasks, and IADLs, the instrumental activities of daily living, being those that really allow a person to live independently. The first being things that we kind of had to learn to go to kindergarten, to dress, feed, ambulate, toilet, and perform our own hygiene. And then IADLs, those we kind of had to learn in order to go off to college. You can think about it that way. Independence with ADLs does predict independence in the home, and independence with IADLs predicts independence in the community. So defining the functional status of the patient really helps understand the risk and the circumstances related to their goals in rehab. So looking at, cognitive deficits and how they have, or that they have a significant negative impact on activities of daily living and on quality of life. Memory and planning problems affect things like dressing and grooming and cooking, all skills that are needed for independent living. Attention issues and visual processing deficits increase the risk of collisions and trips and falls. Cognitive deficits can cause mood issues and motivation problems. I'm going to go on to look at them a little more specifically. So attention, normal activities require specific components of attention, and one or more types of attention is necessary for pretty much all the activities that people enjoy. You can see just a man playing a game there and having to be alert to play that game. Selective attention, below that, that's the ability to focus attention onto a particular stimulus while ignoring other stimuli. Selective attention provides that filtering that's required for things like speech recognition, so it's necessary for socialization. Focused attention is needed for reading or hobbies. Sustained attention or vigilance is just what it sounds like, maintaining attention on a stimulus or task. Sustained attention is required for understanding the context and the content in movies, television, or books. Visual spatial attention is that ability to change the attention focus from one stimulus to another, usually from one location in the visual field to another. Shifting focus is required for things like crossword puzzles or other hobbies. Divided attention is that ability to focus on two or more stimuli at the same time. Divided attention is necessary for things like dancing, which requires a response to multiple stimuli, for a lot of activities. So imagine how a disturbance in attention can affect a patient's quality of life, those things that they enjoy the most, hobbies or reading, television, socialization. Those things become so strenuous that a person begins to avoid them. And that lack of healthy activity has a tremendous impact on physical health. Looking at memory and activities of daily living, using a kind of a practical definition of memory, the ability to encode, store, retain, and subsequently recall information and past experiences in the brain. Memory is necessary for learning. It's necessary for all activities of daily living. It affects other cognitive functions. It affects cognitive rehab significantly. It's the third most common deficit after a stroke or TBI. It affects about 65% of stroke or TBI patients. Working memory deficits have a significant impact on overall cognitive status. And then in addition to just generally forgetting what you were doing, working memory deficits also affect basic skills such as problem solving and reading comprehension and calculating and reasoning and verbal comprehension. Working memory is necessary for all the basic and instrumental activities needed for independent living, including telephoning, medication management, which can have significant negative impact if there is a deficit, dressing and grooming, meal preparation, money management. All of those are things that people need to be able to perform either independently or have performed for them. But obviously the ability to perform those activities or the lack of drives residential decisions often, what level of care a person needs. And then, of course, working memory is necessary for navigation, both inside and outside the home. As you might guess, a serious memory deficit essentially means the end of independent living. At this point, there's not any compelling evidence to indicate that cognitive rehab can really help to restitute serious memory deficits, but there's some promising new drugs in trial that do seem to promote restitution. There is evidence that cognitive rehab can promote reorganization of memory function, and we have clear evidence that internal and external compensations can be very effective at improving memory function, and that these improvements then transfer to activities of daily living. And again, that applies to patients with mild or moderate memory deficits. Cognitive rehab is not really indicated yet for patients with severe memory deficits. I don't know that yet's the right word, because I don't know that we will have that demonstrated efficacy in the future for patients with severe memory deficits, but we don't right this minute. Okay, next, executive functioning. We define executive function as the coordination of multiple cognitive functions to produce a coherent, goal-directed result. You've heard executive functions referred to probably as the quarterback, and this, or the executive. This assigns cognitive tasks to attention and memory and language and emotional centers and VisuoSpatial Processing. Then the executive kind of coordinates that activity with the purpose of achieving a specific goal. So executive functioning is necessary for purposeful behavior. It's necessary for all activities of daily living. It directs all other cognitive functions. It affects all cognitive rehab. It's the second most common deficit after a stroke or TBI, affecting about 75% of patients. This goal-directed purpose is really unique to executive function. Attention monitors the outside world without a goal. Memory rehearses and remembers without a goal, necessarily. Language centers interpret without a goal. It's only the executive that really works with the purpose of achieving a specific goal. We know that 3 areas of the frontal lobe are necessary for the various executive functions. Again, this is a simplified model that you're looking at, but you can see the dorsolateral prefrontal cortex, the orbital frontal cortex, and the anterior cingulate. All 3 areas have one function in common, although they do different things in general, but they also have one function in common, and that's response inhibition and impulse control. All 3 are essential for all of the executive functions. They don't act alone, and damage to each of the prefrontal areas can cause a fairly predictable set of specific executive deficits. Deficits in these areas are often underestimated or not perceived at all by the patient, and they're very difficult for family members and friends to understand and deal with. And this really causes significant problems with family and social and work reintegration, residential settings, which are some of the most common long-term effects of brain trauma. Only some of the executive functions are amenable to cognitive rehab, but attention and working memory and problem solving, as well as decision-making skills. It's those social and emotional dysfunctions that are not amenable to cognitive rehab, but they can be addressed with behavioral or other interventions. So the dorsolateral prefrontal cortex, or the central executive, is involved with problem solving and calculating and reasoning, information processing functions such as attention and working memory, and integrating cognitive functions. Other dorsolateral functions include planning and follow-through, abstract thinking, cognitive flexibility, which is the opposite of perseveration, acquiring new skills, and adapting to new situations. The third area involved in executive functions is the orbital frontal, the anterior cingulate cortex first. And that's involved in motivation and anticipating rewards, emotional awareness and empathy, error identification, and impulse control, as I mentioned earlier. Lesions here in this anterior cingulate cortex can cause blunted affect, poor impulse control, or lack of motivation, from a generalized apathy to a lack of motivation for something specific like eating or even moving. And of course, damage here can cause problems with emotional awareness and interpreting other people's behavior and motivations and emotions. And it can easily disturb the patient's ability to empathize with others as well. And then the third area, the executive function is the orbitofrontal ventromedial area of the prefrontal cortex. And there's some debate about the exact borders here, so we're just I'm not going to pay attention to that right now. But this area is involved in decision making. the valuation of rewards and punishments, the evaluation of emotional experiences, for example, even experiencing embarrassment. So emotional regulation, self-monitoring, and impulse control. So damage here can cause risky behavior, emotional outbursts, including aggression and crying, anxiety or depression. Other possible symptoms of ventromedial damage include gullibility, socially inappropriate behavior, or disinhibition. And then visual-spatial processing, and this is defined as the analysis of complex visual stimuli which allow us to perceive whole objects and the spatial relationships among them. Visual-spatial processing is not vision. It's not the visual field. It's not the function associated with hemianopsia or neglect or saccadic movement. Visual-spatial processing is not visual attention. It's the cognitive processing of visual information that allows us to see objects in their entirety and to understand spatial relationships between objects. So this is really our predominant method for processing information about the world around us. It's subconsciously driven, and it's difficult to explain to someone else, but it affects all other areas involved in cognitive rehab, and it affects all areas of activities of daily living. And the frequency of impairment after stroke or TBI is 30 to 50% after a left hemisphere trauma and 50 to 70% after a right hemisphere trauma. Visual constructive skills include copying a drawing and assembling 2 and 3D objects. The drawing on the lower left is from a patient with a visual spatial deficit. Reading requires processing of shapes and positions. Depth perceptions needed for grasping objects. Orientation and navigation in the environment require mental mapping. Interpreting angles is necessary for reading a clock. And mental imagery and 3D assembly are needed for dressing. So you can see, again, that visual spatial skills, there's the slide that goes along with what I was just saying. Depth perception that's needed for grasping objects, So visual spatial processing and ADLs. And then other problems caused by visual spatial deficits are, of course, things like collisions and trips and falls. Visual field deficits are different. The visual field's often a focus of cognitive rehab. It's basically that spatial array that's visible to a person without looking around, so your peripheral vision. A visual field deficit is a loss of a portion of the visual field. And again, this is a neurocognitive visual field deficit. This is a visual field deficit caused by a brain injury, not a visual injury or an injury to the eye. These are, again, common in stroke patients. They're uncommon after TBI, but possible. TBI patients more often do have real visual problems, ocular or oculomotoric problems, rather than visual field deficits, although there is some concern that visual field deficits are underdiagnosed in the TBI population. Patients are generally unaware of visual field deficits. They may bump into things or people. They may blame problems on other causes like poor lighting. If they do recognize they have a visual field loss, they do often think it's a visual problem. These are pictures from a study based on glaucoma patients, but they're used here to illustrate the effect because stroke and TBI patients often do experience this same fill-in effect that I'm going to describe. So on the left here, you can see 2 kids running into the street after a ball. This is a view from an approaching car. As we see, the driver has a relatively normal visual field, but on the right, you see the view for the driver with a visual field defect. And this driver is completely oblivious to the children. And the defect area is filled in. This is how the brain corrects the scene. So it doesn't cloud it over or leave blank areas. The brain fills in the area to include the background just without the children. So visual field screening and therapy, screening is recommended for all cognitive rehab patients and often for therapy patients as well. Visual field deficits impact so many areas of ADLs, telephoning and shopping and dressing and grooming, again, money management and meal preparation. And then I'm not going to go through hemispatial neglect other than to say that it is different from the visual field deficits that we just talked about, but you can see on your handout a little bit of information about what it looks like. Neglect and ADLs, you can imagine that those cause a tremendous impact on rehab, tremendous impairment on the rehab process as well. So just to point out, though, that there is evidence that cognitive rehab can promote the reorganization of memory function. We have clear evidence that internal and external compensations can be very effective at improving memory function, and that these improvements transfer to ADLs. Executive functions appear to be amenable to all three forms of recovery. VisuoSpatial processing appears to be amenable to restitution. There's compensation strategies, and there's evidence of reorganization of visual-spatial functions to the contralateral area of the brain. Visual field deficits are amenable to restitution, reorganization, and compensation. There's no specific therapy for neglect, what I just showed you, but neglect is amenable to all three recovery mechanisms. More than half of affected patients of visual neglect, recover through spontaneous restitution. And I should say, I'm sorry, I'm going back a slide. That's what this is a demonstration of, a self-portrait over the period of 8 months, and this is spontaneous improvement. Okay, again, the evidence for cognitive rehab is pretty clear, and the details of which can be found in ongoing studies and in the literature. This is a tremendous meta-analysis if you're interested in additional information. There are some practice standards that go along with, and from you can see here for the different types of intervention on the left and the recommendations on the right. Here is my email address. It is 11:02. I apologize. Thank you very much for sticking with me, and please do email me if you have any questions.